Mas Rere, mana Mas? Mas Rere? Assalamualaikum Dr. Azlida. Assalamualaikum dokter.
Waalaikumsalam. Halo.
Iya.
Selamat siang.
Halo dok. Selamat
Hi.
siang.
Well, that's
Akhirnya.
nice speech behind you.
Iya.
I'm in my office working.
Maybe 15 minutes later we will start the class.
All right. Should I share my slide now? Is that right?
Yeah, okay.
Let's
I can share screen for the presentation.
Okay, wait.
Yeah. Good afternoon, Dr. Azlida.
Good afternoon. Yes.
Yeah. My name is Aulia, doctor.
Hi, Aulia.
Yeah, I'm appointed to be your moderator today.
All right. So can you see my screen?
Yeah.
Yeah.
Yeah, we can see.
Should I do full mode then, or should I do this or wait like this? Better?
Yeah.
Yeah.
Okay.
It's good.
Wait, I plug on this one. Wait for a while.
Yeah. The speaker is okay, doc. Speaker.
I can hear you, but I'm not sure that can you hear me well?
Yes, we can hear you well.
Okay, good.
But your voice is a little low.
Okay,
Maybe.
so, how about now? Sure. Wait, maybe I should close the door. I close the window now. Okay. Is it better?
Yeah, this is better.
Okay, sorry about that.
Yeah, it's better.
I just checking. So during the presentation, students are allowed. We can have some interaction like Q&A session, or should I just continue until the end, or what is the plan?
We have a question and answer in the last of.
Okay, so I just continue until the end of the session.
Until the end of the section, okay. And we will read the question in the end of the.
Okay. So all year 1 until year 5 students, or just how is it clinical students or?
Undergraduate student and resident of
pediatric dentistry resident, doctor.
What I mean is, the undergraduate, are they all first year or all clinical students, or is like all students?
The all student.
Yeah, the all student. In third year student. Third year student. Okay.
Right. Okay.
Yeah.
Third year student and pediatric dentistry residents. Right. So
they have seen patient. They have been dealing with patient. Year 3 at third year student.
In third year student. Not yet clinical.
I can't hear you.
Yeah, Dr. Azlida, do you mind if I mix the language between
sure, of course.
between Malaysia and Indonesia?
Boleh.
Okay. How are you, doctor?
I'm good. How's Indonesia? COVID-19?
Yeah, here the number is still rising, and we are not
lockdown, right? No lockdown measures.
No lockdown. Okay. No lockdown. Okay. Our government is didn't want to lock down the several area because they think about economic condition.
True. We have passed the lockdown period. We back to work in June, but now there's suddenly last week there was a rising case in Kedah. Do you know Kedah, Langkawi?
No, never heard about it.
So they have like a targeted lockdown now in Kedah, in one of the states. So because last week there's a surge of cases in the area, and plus there's an island area where people go for holiday because recently we have long weekends. So hopefully after that things get better, hopefully it won't go to other states lah.
Yeah, hopefully.
All of you are all online learning now, or you all?
Yeah, online class.
Okay.
Online learning. How about in Malaysia, doctor? Is the student already attend in university or?
Yes, yes. We actually, for medical and dental students, they can come back since last June. Postgraduate students also already come back including doing patients, but we have spent a lot on PPE. But for the other courses, still online learning until December. But for our faculty, last June only final year, so they have finished the exam. So for just this week, the year 4 students coming back because they need to catch up the previous semester that they have stopped. So they're about to, we call it a pre-session. So they have to some sort of like try to catch up requirement that they have missed in during the lockdown period. But they only have like 3 weeks basically, the additional so-called pre-session before
final exam.
they're coming back. I mean, a full blast October. But a lot of money.
The host is announced that 10 minutes the students will joining us in 10 minutes.
All right, okay.
If you need any assistance or help, you can tell me, doctor.
Okay. So you all 5 years program or 6 years program?
Oh no, I already graduate.
For the undergraduate in Erlangga. So is it a 5 years or a 6 years program?
5-year program.
Okay, so same with us. So pre-uni, 1 year or 2 years? After high school, do you have
preclinical? Ya?
No, not preclinical. Like A-level kind of thing.
Kita nggak ada A-level sih, Dok. Ya nggak, Mbak? Kita nggak ada A-level.
Matriculation or pre-university, no?
No, we directly go to university after we graduate high school.
So you graduated younger than us then?
Dr. Azlida?
Yes, yes.
Did you do private practice there?
Yeah, I used to, but now I'm in university, so I no longer, I mean, after my postgraduate training, I've no longer did private practice because you got so much to do now, so enough time to I mean we can if you want, but it's by choice lah, whether you want to do both or you just want to do in the government sector, or it's up to us. But at one point I decided I no longer want to work in private practice. So because last time I did both, but now I full with the university.
Yeah, because of the COVID-19 pandemic, this
before that
there is
I've not been in a private practice. I think for a few years now, because I still do here clinical practice here, but not in private, because in Malaysia, if you are in a government sector, if you want to work for private, you have to apply so-called like locum, kind of like you have to put it in your annual practicing license, all the new additional practice that you've been involved with. So you need to have additional insurance, and also you have to fulfill that criteria. Because in UM, we have private wing as well, University Malaya Specialist Center. So some of us actually do both. You few days here, few days in a private wing, but still under University Malaya so-called service lah. You have that in Erlangga, or you can only decide one practice?
We can do our private practice outside in Erlangga University Dental Hospital.
Okay.
Like me, I have my own private practice here. Yeah.
Oh, that's nice.
You can see
Aspiration.
here.
So now, how about COVID? So do you still do? I mean, patients?
Yeah. Yeah. I still treating a patient, but I selected the case like emergency case only, because we are having a difficult to provide level 3 PPE, like extra oral suction, like aerosol suction. That is mandatory thing here in Indonesia.
Very expensive though.
Yeah, it's really expensive, and the patient needed is below of the demand.
Yes.
So if we buy, I don't think that it
they cover the cost, isn't it?
Yeah,
because my friend in private practice, they'll see the volume of because they will ask additional charge for PPE. Patient has to pay for their PPE on top of their treatment. If not, they cannot survive with, the cost of PPE itself is very expensive on top of the treatment. So some of our private practitioners are, offering that to patient. If you want to do AGP, this is cost that you have to pay, because those who are emergency basically don't do much, right? Medication, relief pain and all, but AGP actually that where you get most of the money.
Yeah. And
That's true.
We cannot use the regular surgical mask. We have to use respirator one. Yeah.
So that one also expensive, isn't it?
Yeah.
I see quite a number in waiting mode, so you have to admit them. Okay.
Good afternoon, Dr. Aslida.
Hi, selamat siang, betul ya?
Selamat siang. Thank you so much for coming for this
Thank you
event.
for inviting. Thank you for the invitation.
Yeah. Dr. Taufan is the one who usually communicate about this matter, because I am not personally in touch with you before.
Is it you or there's another Dr. Ninuk?
Yes, my name is Dr. Nino. I'm from Dental Public Health as well.
Okay, sorry. How should I?
Okay. Rara, sorry, I just realized that I come in using the Edu9 Zoom. So maybe I leave out first and then change into my own Zoom.
Okay,
just
dokter.
in case someone using it.
Okay, dokter. Dokter Gea?
Ya.
Dokter, mungkin saya bisa diberitahu ya kalau misalnya sudah mau akan dimulai?
Iya.
Ya, terima kasih.
3 minutes later ya, dokter.
Okay, all right, I'm ready.
Mungkin mau mengingatkan lagi untuk mahasiswa untuk mahasiswa semester 5 ya, untuk namanya bisa diganti sesuai dengan yang sesuai sama arahan. Kalau ada temannya yang belum masuk, tolong segera dikasih tahu untuk segera masuk. Soalnya 2 menit lagi kita mulai.
Udah? Oke.
Ini apa dulu sih? Oh, tahun angkatan. Nomor, rename.
Oke, Dokter Ara, kita bisa mulai sekarang aja. Sudah jam 2.
Ya, saya izin memulai, dokter.
Okay.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Selamat siang semuanya. Selamat datang di kelas IKGM 3. Perkenalkan, nama saya Aulia yang akan menjadi moderator di perkuliahan sore hari ini. Di hari ini, kita kedatangan seorang special guest yang akan membagikan ilmu dan insight baru mengenai dental caries prevention kepada kita semua. Beliau hadir jauh-jauh dari negeri seberang. Sepertinya beliau sudah bergabung bersama kita ya. Assalamualaikum, good afternoon, Dr. Nur Azlida.
Yeah, good afternoon. Selamat sore. I'm not sure which one.
Ya, sekarang di sini sudah jam 4 sore, dokter. Iya, baik. Mungkin kita akan berkenalan lagi ya, dokter ya. My name is Aulia, dok. I'm appointed to be your moderator today.
Yeah, hi, Alia. Thank you for your kind introduction.
Yeah. Do you mind if I mix the language between Melayu, Indonesian, and English?
Boleh.
Terima kasih, dokter. Thank you. How is it going now in Malaysia, dokter? Are the students still having online classes or they already attend the university?
Previously, we only have year 5 coming back in June and July. And now this week, we're just about to have year 4 students. So we bring them back by staging for them to catch up their clinical requirement. But the rest, like year 1 and year 2 does not involve patients. So they are still on online learning. But other faculty, apart from medical and dentistry, they are still in UM. They have to do online learning until December.
Ya, oke. Mungkin Dokter Taufan Bramantoro sebagai Ketua Departemen Ilmu Kesehatan Gigi Masyarakat atau Dokter Nino juga ingin menyapa Dokter Nur Azlida, Dokter. Dipersilakan. Dokter Taufan, apakah sudah hadir ya? Assalamualaikum, Dokter Taufan. Sepertinya belum ada jawaban. Dokter Nino Haryani mungkin ingin menyapa Dokter Nur Azlida, Dokter. Ya, Dokter Taufan dan Dokter Nino.
Dokter Taufan sudah masuk, sebentar.
Dokter Taufan sepertinya sudah masuk, tadi saya lihat ada namanya, tapi sepertinya belum memberikan respon.
Okay, sorry, it's a mute position. Okay, maybe Dr. Taufan, want to say something?
Yes.
Hi, Frankie.
Finally, I can speak because my microphone is locked by the host.
All right. Okay.
I cannot taking a voice in my microphone.
All right.
Okay, hi. Assalamualaikum, Dr. Azlida.
Waalaikumsalam. Thank you.
Finally, we meet in.
How are you, Prof?
Alhamdulillah.
Hope everything is getting better in Indonesia. Yeah.
Yes, I mean, I heard that in Malaysia is already better for the condition.
Yeah, it was very much better for the last 2 months. But however, last week we started having surge of cases in 2 states, in Kedah and Sabah. And Kedah now they have 1 district currently in lockdown because just a sudden increase in the area. But the other states are fine, so we are okay because it was like a lockdown period for 3 months. Yeah, last time March until June. So now we are actually already in office do a standard. I mean, go back to our normal life, so-called normal, but with all these masks on and social distancing.
Oh, I see. Hopefully, in Indonesia will be get the same condition. Amin. Okay, Dr. Azlida, thank you very much. I really appreciate it that you can join with us to give the lecture about the preventive dentistry update, especially regarding the fluoride topics. And I think it will be very great information for our student, and it will be a very useful information, I think, for all of us. Thank you very much, Dr. Azlida. And saya kembalikan ke Dr. Aulia. Silakan.
Thank you, Prof.
Thank you, Dr. Azlida.
Ya, terima kasih Dr. Taufan. Dr. Nino mungkin ingin menyapa Dr. Azlida juga sebagai PJMK IKG M3, Dokter.
Okay, thank you for the time, Dr. Aulia. I want to take this opportunity to welcome you, Dr. Azlida, and maybe this is our first in touch. I want to say our gratefulness for your time that you provided to us to share the knowledge about this upgrade in the preventive dentistry. I am the course coordinator in this class. I hope that our students could take this opportunity to get more knowledge in this matter. So I'm sure that you are very busy. So thank you so much for your time. And thank you for the time, Dr. Aulia.
Thank you, Dr. Nino, for your kind introduction. I hope students will learn something. Maybe some of it they already knew. It's just a refresher, yeah.
Terima kasih Dr. Nino. Ya. Before we start, I would like to read the curriculum vitae of Dr. Nur Azlida. Mungkin Dr. Gea bisa dibantu untuk share screen-nya ya, Dokter?
Should I stop share first?
Oh yeah,
Okay.
please. I'm sorry Dr. Azlida. Ya, Dr. Gea mungkin bisa dibantu? Ya. Baik. Ya, oke. Dr. Nur Azlida Mohnor. She is a staff of Department of Community Oral Health and Clinical Prevention, Faculty of Dentistry, University of Malaya, Kuala Lumpur, Malaysia. She had her bachelor degree of dental surgery in University of Malaya in 2008. She had her master degree in dental public health in Queen's Mary University, London in 2011. She continued her postgraduate diploma membership in Royal College of Surgeons, England in 2011. And she had her PhD in dental public health in Cardiff University in 2018. We can see on the research and publication section that her research interests are in fluoride. Dr. Gea, can you please? Fluorosis, dental caries, and health behavior. For your information, if anyone wants to ask question, please simply press the raise hand button or type your question in the question box. Jika ada pertanyaan, bisa langsung mengklik raise hand button atau mengetikkan langsung di kolom chat. Okay, without any further, please welcome Dr. Nur Azlida.
Can you all see my screen now? Can you see the slide?
Yes, Doctor, we can see.
All right. So thank you so much, Dr. Aulia, for kind introduction, and Prof. Taufan, and also Dr. Ninook for your greetings. Yeah, very warm greetings from University of Erlangga. Thank you for this opportunity. So I think I shall start. I think we almost 10 minutes on the introduction. So basically, today we will be discussing about fluoride. So I think some of it, maybe you already knew the information. Maybe I just share some of the latest research or evidence on certain component. So also to discuss evidence-based guideline in relation to use of fluoride for caries prevention, and also to compare advantages and disadvantages of different fluoride deliveries. All right, so basically, I think you all know this. So for this presentation, so I put it the classification as systemic and topical fluoride. So for systemic, those that I bold, like for example, this one, yeah, under systemic fluoride, like water fluoridation, salt fluoridation, milk fluoridation, and fluoride supplements, I will cover very much, try to cover very much as possible. But for topical fluoride, because the topic is a lot, so I focusing on three types of topical fluoride, which is I think the most commonly used among clinician, and also very relevant to undergraduate students. Yeah, so which is fluoridated toothpaste, and also fluoride varnish or gel, and also I think the more getting in the literature is silver diamine fluoride now, SDF. So I will just touch a bit on that. All right, so I think this is, I think you all know this, right? Just a refresher, how does fluoride work for caries prevention? So basically these three components, fluoride inhibits demineralization. These three components commonly cited in the literature. Promotes remineralization. I think because we know, right, caries due to the balance between remineralization and demineralization. And the third component is inhibit bacteria growth or reduce acid production. But actually, if you look at the literature, item number 3 is most of the paper or literature are focusing a lot on the in vitro study. So actually, there's a lack of evidence on how the it works on the actual human beings lah. All right, so I think for these items, I just would like to share some of the evidence. Yeah, so I think for water fluoridation, I was informed Indonesia not having any national water fluoridation scheme, right? Apart from sharing evidence, I may also share what's been done in our country, Malaysia, in terms of fluoride in caries prevention. So in terms of water fluoridation, there are several key systematic reviews that actually discussing on effectiveness of water fluoridation. Maybe you already know this one is York review, and then the recent one we have Cochrane review, and also several from Australian reviews where they have several updates as well, 2 updates now. I think all of this review actually acknowledging the effectiveness of water fluoridation. They actually put together all the information. But of course, there's a lot of issue or debates in terms of type of study that evaluate fluoride in the water, because it's all cross-sectional in nature. Because I think we know that it's very difficult or not feasible to do randomized control trials. So people are challenging in terms of type of study that's been involved. That's why in the recent Cochrane review on water fluoridation, they actually become very stringent in their type of study that be included in their review compared to the York review. So actually being criticized and challenged in terms of how they conduct the review because of the nature of the intervention, water fluoridation intervention. So and then in the recent evidence, because in the previous review, people are talking a lot of information about how the water fluoridation effective in caries prevention among children, but lack of evidence on adults. So we notice in the literature, a more recent one, there's a lot of more papers actually discussing on effectiveness of water fluoridation in caries prevention among adults and elderly groups. So there's more evidence coming for that. And then also quite recently, we have evidence on the impact of stopping water fluoridation on dental caries prevention. Because I think there are certain countries, for example, in Scandinavian, they stop water fluoridation, but they still see a reduction of caries, although they stop. So actually, if we look at the evidence on stopping water fluoridation, I think I will touch already on the next slide. In terms of issue with when you stop fluoride in the water, what happened to dental caries? Okay, so as I mentioned earlier, based on the best available evidence, actually very favorable to water fluoridation in terms of effectiveness in relation to increase more caries-free population, reduction in caries experience, and also caries incidence. And all these reviews actually only reported the only side effect they reported is only dental caries. So other issues, for example, cancer, bone defects, or carcinoma, and all is actually there's no scientific evidence to actually support that kind of claim. Right. So this is just now I mentioned a new evidence on effectiveness of water fluoridation on adults group. So most of it coming from Australia and Australia and US. Okay. So we also in Malaysia try to because we have water fluoridation. So because a lot of our evidence also on among children, we also would like to look more in terms of how does it benefit to the other groups, adults and elderly. All right, so this is the issue with what happens if we stop fluoride in the, water fluoridation. So actually, this study, McLaren and Singal, so actually they combine all papers regardless of type of study design, historical control, negative control, any studies that actually reported on the impact of stopping water fluoridation on dental caries. They actually included in the review, but actually they found mixed results. So 5 studies shows increase in caries after post-cessation, and also there are 3 studies that did not show any increase in post-cessation, meaning that if you don't have any fluoride in the water, you still can see the decline in caries reduction. Because in the York review, they also analyze the impact of stopping water fluoridation, but their result also show towards beneficial impact, meaning that if you stop fluoride in the water, there's a tendency of having high caries. But because of the different type of study designs included in the review actually differentiate the difference in the data analysis for both reviews. Yeah. All right. So, okay, this is maybe, I'm not sure whether because Indonesia does not have water fluoride in the water, right? So maybe the concentration might not be an issue in certain country, but for us, for example, in the country whereby we have fluoride in the water, there's a lot of changes happening because of different exposure to fluoride, different sources of fluoride. Now we have fluoride in the food, fluoride from toothpaste, fluoride from different sources. So actually, over time, several countries of fluoride policy statements being reviewed. So we noticed that several countries, for example, Hong Kong, Singapore, Ireland, and US have a tendency already reduced their optimal fluoride level. For example, if you look at the WHO recommendation, the lower end is actually 0.5, and the upper end, I mean the higher level, the maximum that we can go is actually 1.5. But majority of the country that have water fluoridation, usually they do between 0.5 to 1 parts per million. Okay, so in terms of the adjustment towards downward adjustment, for example, Hong Kong do this twice. Okay, last started with 1 parts per million and they reduced it 0.7 and they reduced even further to 0.5. And Singapore did the same. And then Ireland from 1 to 0.7. And also US, yeah, from 1.2 to 0.7 in 2019. So for Malaysia, we also reduced our water fluoride level in the water from 0.7 to 0.5 in 2005. So for all these, if we look at the rationale, is increased exposure to multiple fluoride from different sources, and also increase fluorosis. For example, for our country, there's issue with fluorosis prevalence. And also, if you notice, the country with warmer climates, yeah, for example, Hong Kong, Singapore, Malaysia, we are in the tropical climates, have a tendency of going for lower, to the lower end, with the assumptions that relationship between water intakes, for example, those who are in a warmer climate drinks more water, something like that, yeah. But actually in US, they did that study, but actually they don't see any difference in terms of climate change. All right, so I've wrote some articles, I think very simple article for undergraduates to read. If you want to read more, you can just scan the QR code, right? So, right, so I think I'm sure you've been taught about advantages of water fluoridation. So actually, people are talking about cost effectiveness apart from being effective, proven effective, and also it reaches all groups in the population. Yeah, it's go to regardless if the pipe system is good, it's actually the water can reach to wider population, and we don't have an issue with compliance because we drink water, right? I mean, everybody will drink water, and then cheap, safe, and also a little manpower required. Okay, I think the benefits you have seen this in the previous slides, issue with caries reduction, beneficial to lower rate progression of caries lesion, and so on. I think this one quite straightforward, yeah? All right. So, but however, we know there's a controversy with water fluoridation implementation, okay? So, we issue with anti-fluoridation group. I think in many countries, there's a lot of issue with anti-fluoridation groups, similar to our country, Malaysia as well. And I think the similar narrative being brought by this group, issue with human rights, right? You cannot force people to take fluoride and things like that. And then also complexity of implementation for certain countries, for example, countries that do not have good piping system. Of course, fluoride will become less priority, isn't it? Their priority is to get good piping system first. So that's some issue for certain states like in Malaysia as well. And then also increased use of water filters in certain population. Maybe this one may be specific to certain countries issues as only, because for example, this is the biggest challenge for recent years in Malaysia in terms of water fluoridation, because more and more people started to use water filters, not because they want to remove fluoride, but because the assumptions of water not very clean, and they wanted to have option for hot water directly, right? If we have water filters for our country, you got several options like hot, cold, standard water, and all. So people wanted that as a convenient, but eventually most of the filtration system actually remove fluoride. Okay. So another systemic fluoride is fluoride supplements. Yeah, it can come in tablets, drop, or chewing gum, or lozenges. But this one, I think, not that popular among certain countries only initially. Yeah. So in terms of evidence, it was proven effective but subject to the individual compliance. All right. So for example, in the more recent years, I think not many countries opt for this approach anymore, although it's targeted high risk group, people with high caries risk. But the thing is, it become less favorable because of long-term compliance, because we can only see its effectiveness if the children take the fluoride supplements. Yeah, so and a lot of issues they have to consider in terms of dosage schedule, their fluoride history and all, but usually only being used in the area where there's fluoride deficiency. Yeah, all right. So next one is salt fluoridation. So this one also quite popular in certain countries that do not have water fluoridation, because WHO has approved this public health intervention as alternative to water fluoridation. I think it's popular in certain countries like in the European, because they don't have water fluoridation, and it's quite easy for the manufacturer to implement this. But however, in terms of evidence, if you look at evidence, there's no strong study design like RCT or anything to actually say it is an effective approach. And also there's an issue whether this approach is actually suitable for children, because it's very difficult, right, when we have conflicting messages whether to take more salt, because there's an issue with also general health advice. Yeah, so this is the advantages and disadvantages. For example, contradictory public health messages to encourage the reduction of salt, or because it's actually lead to hypertension. But there's a lot of solution being put forward under the country that have this, so there will actually some suggestion like people do not need to change their usual behavior because they take salt when they cook or things like that, but actually may be suitable for adults population but not really for children. Okay, advantages, I think issue with cost is very minimal compared to the investment to water fluoridation plantation, and also the coverage is actually quite good for adults population, and also effective in if it's been conducted well, is some countries have proved effectiveness. Yeah, all right. So next one is milk fluoridation. Country that do not have other in fluoride deficient. For example, in the UK, because there are because only 10% of the population being fluoridated. So certain area with high caries risk, what they did was they actually incorporated with fluoride in the milk. Yeah, so that to cover those with high caries, but at the same time they also take good supplement like milk. Okay, but again, not many countries, only several countries actually implement this, and also require a lot of issue with compliance, whether the level is being complied from the company and so on. Yeah. All right. So what is for example, just to share what happened to Malaysia. For example, because we have water fluoridation, so our policy statements on fluoride therapy, we only support one systemic fluoride, so which is currently water fluoridation, and we go for 0.5 parts per million, and we did not recommend any other form of fluoride, systemic fluoride like supplements, salt fluoridation or milk fluoridation, because actually we have several countries approaching Ministry of Health to do salt fluoridation and milk fluoridation, but currently the decision is still to go for water fluoridation. I think similar to Australia and other countries, usually they only opt for one systemic fluoride approach. All right, so that's on systemic fluoride. Okay, now we move to topical fluoride. So basically I will cover on toothpaste, because there's quite a lot of information on fluoride toothpaste itself. And then I will touch on fluoride varnish, gel, and silver diamine fluoride. Are we okay so far? Okay, so I think maybe postgraduate, I was informed there are also postgraduate in this seminar. So I think you're all aware there's a list of fluoride review under Cochrane Library. So I think if you want to go and read more, of course, you can go and read more, but I just list down a few here, which have series of topical fluoride reviews, yeah, that they also have subsequent and also updates as well. So if you want to get further information, most of it I'm taking from this review, yeah. So I think issue with fluoride toothpaste, almost, I think we have seen this in all literature supporting or proven effect. Fluoride toothpaste is proven effective in caries prevention, regardless whether we have exposure to water fluoridation or we don't have exposure to we have exposure or not exposure to water fluoridation. And the advantages were it's convenient and culturally accepted compared to other form of fluoride, and it's practical and relatively cheap. I know there's some issue with cost of toothpaste in certain country, but in our country is how to say, relatively cheap to buy fluoride toothpaste. Yeah. So, but however, when we talk about fluoride toothpaste, there's a lot of factors associated with what advice should we tell our patient, or what advice should the healthcare professional be trained to give to the population and also to the community. All right. So we have issue. We notice there's some so-called like lack of consensus in the literature regarding age, yeah, when actually children should start using fluoride toothpaste. Yeah, I think this one a bit lengthy. I just go to the table. All right. So we reviewed several guidelines. In fact, I think a lot of papers also been doing this. Review a lot of clinical guidelines from different countries. So as you can see from the table, there are some so-called slightly different approach by different country, subject to their fluoride level in the community as well. So, for example, if you can see from the table, in terms of let's start with concentration. Yeah, in terms of concentration for children, less than. For children less than 3 years, yeah, when to start. So in terms of age, a lot of study will say as soon as the tooth erupt. So we have to start brushing teeth by then. But whether to use fluoridated toothpaste or not is actually, we can see there's some discrepancy. For example, the first 3 countries, Australia, Ireland, Hong Kong, they actually did not recommend the use of fluoride toothpaste for children less than 2 years. Okay, for Australia, less than 1.5 years, or less than 18 months. But for other countries like UK, New Zealand, US, and Canada, they're actually advising use of smear fluoridated toothpaste. Similar to Malaysia, we actually recommend smear fluoride toothpaste for children less than 3 years. Okay, so and you can see also the difference maybe could also be due to some of the exposure to the fluoride in the water. Right. So another one is in terms of use of toothpaste for children between 3 to 6 years. I think the issue with among the children less than 6 years were because of the risk to develop fluorosis, right? If you got excessive injection during this period of time, less than 3 or less than 6 years old for premolars and posterior teeth. So issue with to make sure the balance between caries prevention and also to minimize fluorosis. So for example, in Australia, I think this is the only country that I observed from the literature that's still suggesting 500 to 550 parts per million, unless for high caries group. But for the standard advice, it's still considered low concentration of fluoride toothpaste. Yeah, for example, in other countries like Ireland, Hong Kong, UK, New Zealand, US, Canada, they actually go for 1,000 parts per million. All right. So and also issue of size. So I think there's some consensus in terms of P size for this age group. Another consensus that we can observe from the guideline is actually supervised brushing and also the times, which is 2 minutes. I will get to that in the next slide. Yeah. All right, so in terms of supervision, I think all guidelines, there's a consensus that children less than 7 years must be supervised for toothbrushing, because from a lot of literature reported that if children who've been supervised with during toothbrushing have further reduction of caries compared to the non-supervised toothbrushing, and caries preventive effect is actually better even at school-based, for example, for public health or school-based toothbrushing activity, those who've been supervised has better caries reduction compared to the non-supervised group. All right, so frequency of brushing, if you look at Cochrane review, what they say is once is actually beneficial, but if you use twice or more, is actually increase the benefit of the caries reduction or caries prevention. So majority of the guidelines suggesting two times per day lah. And then issue with brushing twice daily elevated concentration of fluoride in the oral cavity where it can inhibit dissolution of tooth mineral. All right, so in terms of fluoride concentration, yeah, as I mentioned in the earlier table, and also from the review, actually, most of the review suggesting that evidence suggesting 1,000 parts per million is effective in caries prevention. Okay, there's some issue with the low fluoride toothpaste, those who are 600, because initially similar to our country. So initially there's an issue whether children use this one or use children toothpaste, because in our country, some of the children toothpaste still marketed at 500 to 600 parts per million, but adults toothpaste majority were 1,000 and above or 1,400. Okay, so because again, there's an issue in terms of, I think for certain countries, like for example, Australia, that because when they do their analysis, they notice that from their local evidence indicate that fluorosis coming more from the toothpaste rather than exposure to fluoride from the water. So that's why I think they go to reduce fluoride in the toothpaste instead of reduce fluoride in the water. That's their justification. All right, so again, the previous review from Cochrane as well as the recent Cochrane review reported the same argument where for effectiveness, we must have at least 1,000 parts per million fluoride in the toothpaste. And they conclude that toothpaste containing lower concentration fluoride are ineffective. However, evidence if you look at in the review, evidence on low fluoride concentration for caries prevention is lacking. So because studies included in the Cochrane review basically comparing 1,000 with placebo or 1,000 with non-fluoridated or 1,000 with a very low fluoride concentration like 250 parts per million. So a head-to-head comparison is between 1,000 to 500 to 600 are lacking actually. So for example, certain countries, for example in Ireland or UK, they argue until there is a new evidence coming to say that 500 is okay or effective for children, they will actually go for the existing available evidence, which is 1,000 parts per million. Although we know the comparison is actually basically between 1,000 with placebo or 1,000 with a very low fluoride concentration. That's why we can see the effect is actually superior. Okay. So okay, I think this is a similar one that I mentioned just now. There's inconclusive evidence for caries preventive effect with a toothpaste less than 1,000 parts per million. Yeah. So all right. So in terms of high fluoride concentration toothpaste, for example, with 5,000 parts per million, it's actually available on prescription for certain countries, which for those with high caries group, like and also children with special needs. But of course, this one requires professional prescription. But for just to share what happened in our country, we don't have this. So we don't have over-the-counter or also on prescription. But from the available evidence, there are countries that have this approach. I'm not sure whether Indonesia have this similar approach as well. All right, so it's also beneficial to treat root caries lesion. However, in a recent paper, by Prati, so it's actually saying the evidence for high fluoride concentration 5,000 is actually again not very conclusive in terms of their superior effectiveness against 1,500 parts per million or 1,000 parts per million, right? So okay, amount, I think I've shown you in the table just now. So there's some issue with smear or pea size, and also I think even in our country, although we actually go for smear and pea size, smear for less than 3 or and then pea size 3 to 6, but there's a lot of practicality argument among healthcare professionals, yeah, among dentists themselves, saying that it's very complex to deliver the information to the family. Have, you know, multiple children, yeah, you have toddlers, you got a preschool, and you got primary school children. So they said and then parents are complaining like, oh, for this one I have to use smear, for this one I have to use, you know, a P, and this one I use full length and things like that. So people are challenging in terms of practicality of the advice. But I think in the ministry level, I also involved with their so-called fluoride document. So actually we use, for example, for public health community-based approach, we always use, for example, toddlers group, go for senior, for the preschoolers, you are P size, things like that, so that make it easier for the you know, delivery of the information. Because somehow they say preschool teachers get confused, parents get confused with some of the information. I think go back to the practicality of the advice, as some claim by our problem facing by our officers at the ground lah, when they're dealing with the community. And in terms of when to brush, I think this is although not all guidelines reported this, but the existing evidence actually suggesting the last thing at night as where we wanted fluoride levels to remain high during when we sleep. Yeah, it was demonstrated, yeah, that after using a toothpaste containing 1,500 parts per million lasting at night, the concentration of fluoride in the saliva were comparable to those found 1 to 4 hours after brushing during the day. So just to show some evidence to support that if we brush lasting at night, that's where we can maintain or keep the fluoride at low level in our oral cavity. Okay, duration of toothbrushing. Basically, there's not much strong evidence to support this, but a lot of professional guidelines suggesting at least 2 minutes. I think the argument is the more you brush, you know, you can mechanically you remove more blood, and also in terms of fluoride, you keep the fluoride longer in the mouth. But in the recent European pediatric guidelines, we noticed they actually highlighted issue with the duration of brushing for preschools. They're actually suggesting at least at 1 minute or 1 minute or more for preschool, because maybe I think we observe very challenging to keep preschool children brush for 2 minutes, right? Even I think observing our own children, preschool children, is very, usually they do very, although with supervision. So I think there's an issue with 1 to 2 minutes in terms of consensus. But for adults or other group of population, I think the 2 minutes so-called quite, consensus in the guideline. Okay. And then in terms of post-brushing behavior, so whether to rinse or not to rinse, yeah, because I think we know that within the limited evidence on this, we don't have much evidence, but within this limited evidence, we know that we wanted to keep fluoride in the mouth for as long as we can. So the issue is, I think a lot of international guidelines actually recommend the spit out, don't rinse. Don't rinse. You just, after brush, you just spit out. You don't rinse your mouth so that you can maintain the fluoride longer in the mouth. And also, I think the recent European pediatrics guideline, they go for avoid rinsing with a lot of water or minimal rinsing. Actually, in terms of post-brushing advice, we also have some so-called argument in our country, because in relation to spit out approach, actually the ministry have tried this approach especially for preschool, because our preschool caries rate is very high. So, but the thing is, the parents' acceptance, our children acceptance are very poor. So especially when we do toothbrushing really at preschool or at school level, they actually have difficulty to just spit out, you know, compare when I was in UK. It's being quite common for their children to just, after brush, they just spit out, they don't rinse. But I don't know, maybe their food, but I mean, different type of food or whatever, we eat curry or smell bad, I don't know. But it's very, we notice it's very difficult for our population to accept spit out only advice. So in the end, ministry does not want to really promote that, but rather go for minimal rinsing or avoid rigorous rinsing. That's kind of advice that we actually provided for our population. But in terms of evidence, when we look at the literature, actually we have they have this paper, yeah, post-brushing rinsing for the control of dental caries. Okay, from this paper, actually, they put a three mode of three advice in relation to increase post-brushing fluoride retention. So one is speed, don't rinse. Second, rinsing with a slurry of fluoride toothpaste and saliva. So I think if you, for example, if you rinse, you have to put some slurry of toothpaste back to your, inside your oral cavity. But I think it's again very complex, right? When we do advise to parents or children about this. Another one is rinsing with a mouth rinse that could be beneficial for caries control at the individual level. So that after you brush and then you rinse. But also there's a lot of argument. Usually people will say, oh, if you want to use fluoride mouth rinsing, you better rinse it not after brush with fluoride, but rather space the time to a different time so that you have with a fluoride rinsing, you can also have fluoride in the oral cavity. So there's a lot of argument in that, but this is I think the evidence that actually suggesting on post-brushing behavior. All right, so that's on fluoride toothpaste. So let's move to the next one, fluoride varnish. Yeah. So I think you all know this. I'm sure at undergraduate level, I think you all have, as experience, applying fluoride varnish to your old patient, right? Or also pediatric patient, for example. So we know this is a high fluoride concentration to 22,000 to 22,600 parts per million fluoride. I think the common one may be what you call it, but Durafat for our faculty. We use Durafat for undergraduate. I'm not sure in Erlangga because there are few brands, right? So if you look at evidence, the available evidence support caries preventive effects of fluoride in both permanent and also primary dentition. And I think the advantages of fluoride is the ability for it to adhere to tooth surfaces. So it prolongs contact between fluoride and enamel, and also improve fluoride uptake into surface layers of enamel. All right, so actually, again, there's some issue when we do fluoride application. How long, how many times, right? So because, for example, there are guidelines saying 2 times, there are guidelines saying 2 to 4 times, there are guidelines saying 4 times. So actually, if you look at systematic review or review articles, they actually, because there's they said that at least 2 times. So that's already proven effective. So if you want to do more, maximum 4. But because the issue is there are some studies saying that there's no difference if you do 2 versus 4, right? So it's actually almost similar caries preventive effect. So actually this one, maybe for a certain country to decide how actually you want to do 2, 4, wherever is actually, I think, go back to our caries risk assessment or CRA approach. Yeah? Okay. And I think in terms of fluoride varnish or fluoride gel application, there's a lot of guideline in relation to their caries risk assessment because they have to do all the CRA approach. Yeah. So again, for fluoride gels, both in terms of effectiveness, I think equally effective. And in terms of professionally applied twice a year, and the concentration is slightly lower than varnish, it's 12,300 to 12,500 parts per million. And in terms of APF gel, the acidulated phosphate fluoride gels, if you notice, I'm not sure which brand you are using in your university, but for example, in University Malaya, what we noticed was manufacturer instruction often said 1 minute application. Yeah, so students sometimes get confused, like, oh, why in the when we give lecture we say 4 minutes application, because this is based on evidence and also literature. But usually manufacturers tend to just put 1 minute in their recommendation. So actually, if we look at inside the literature, they actually reported 1 minute is not sufficient. So we have to make sure at least 4 minutes to make sure, all the mechanism of fluoride on tooth surface is being, properly adhered to tooth surface and all. So usually we go for 4 minutes. Yeah. So in terms of time, again, there's some issue with 2 to 4 per year or 2 times a year. And in terms of gel, I think it's almost a consensus in the guideline. Yeah, they did not recommend this for children because issue of the possibility of ingestion of fluoride gel. So usually for children, they go for varnish. But similar to in in our faculty, usually for adults, we ask preference among patients, whether they want gels or they want varnish and things like that. All right. So in terms of in terms of the difference between gel and varnish, I think effectiveness, if you look at evidence, they are being reported equally effective. But age, in terms of indication, we have to look into their age. And then again, frequency of application almost similar, minimum 2 times a year. And taste, because I think nowadays they have a lot of flavor, like varnish now, they have banana, strawberry, similar to gel. I think patient don't mind because it tastes okay. But for varnish, I think for the children, usually they tend to go for the flavored version. And then position, I think the difference could be because of varnish, because especially children, right? It's very difficult. Sometimes you have to put them, knee to knee position and things like that. So they are okay for lying flat when you apply it. But for gel, usually we always put them on upright position. We don't want them to swallow or ingest the gel. And then suction, I think another thing, that's why varnish quite popular compared to gel, because they don't require suction. You don't have to dry the two surfaces, right? You can just straight away apply it. Okay. And then I think in terms of what I meant by instruction, brief and more involved is that what you're going to explain to the patient. Because, for example, for varnish, you have to give some post application instruction, right? You cannot eat or chew or drink for 4 to 6 hours, and you have to give some issue, maybe there's some staining depending on the brand that you use and things like that. That's what I meant by more information that you have to inform the parents or the patient. All right. So okay. So the next one is I would like to touch a bit on silver diamine fluoride, because I think nowadays there's a lot more and more papers and literature are discussing about silver diamine fluoride, because historically it's being used in Japan, and I think nowadays US have started to approve this, in FDA have started to approve this product in 2015, I guess, and more recently in the UK, and more developed countries started to use this, because after Japan, the most common country that use SDF is Hong Kong and China. So I think there are people who put a lot in the literature about the effectiveness of SDF. So basically, it's a very high level fluoride concentration, 4,800 parts per million, but it's actually more on treating caries, okay, to arrest caries. Because if you look at the literature, there's I think authors keep reporting that there is inconclusive evidence in terms of their effects on caries prevention, but rather more on treating caries, or what you call it, to arrest caries. But the issue with I think if you look at the literature or systematic review on SDF, people are actually a very favorable evidence to support its effectiveness on treating caries, but there's an issue with black staining. So I will show some photograph the next slide. So basically, in terms of staining, because it can cause black staining, not just on the caries lesion, but also if you accidentally apply it on, on the lips or mucosa, is actually also stain soft tissue. But the soft tissue, actually, it can resolve. After a few days, usually it will resolve. But for tooth surfaces, it will remain like that. So in terms of application, usually we have to put petroleum jelly or Vaseline, and then make sure, be very careful, and most importantly, in many I think guidelines is actually emphasizing on having informed consent, whereby we have to inform, if they are children, you have to inform both the children and the parents, and if it's adults patient, of course we have to get the consent from them, and to really emphasize about this side effect, because I think it's also relatively a new product, new materials being used in our faculty as well, because I think initially parents will say, oh, okay, they are happy, they are fine, because sometimes you got like ECC, right, early childhood caries, they already come with very black teeth, but after the treatment, they're suddenly like, wow, it's become very black. So some actually if posterior teeth, that's fine, but anterior teeth especially, I think we have to be very careful if patient, especially if patient not happy with that. And I think issue in terms of indication is very, I think, good materials for to with patient with medical or behavioral problem. Also, I think quite commonly used to treat root caries for elderly and also for special need children, because usually these people that don't really, they cannot come multiple times for conventional treatment, right? And especially for SDF, you don't have to do cavity, right? So usually you arrest caries and you can do your, if patient can come or patient responds to the treatment, they can come later for fillings. But some actually use it just to arrest. They don't do anything after that because patient do not want to come, or there's some issue in terms of limited access to care and things like that. Another thing is, it's very important that these teeth must not be associated with pain or infection. Should be no pulp exposure. So there's a lot of clinical judgment involved when using SGF, and also patient with caries listed that might not be able to treat in one visit. Okay, so especially those with ECC and all, and also the population with access to care is limited. I think a lot of countries, for example, use this for vulnerable, I mean, those who have very difficult to come and there's no access to care, or they do community outreach program and things like that. But in terms of black staining, I think there's a few things that actually come together with SDF, with several effort to minimize the staining. So I think there's a lot more to come for SDF. But I think not just for caries, yeah, I think for pediatrics, I was informed there are some pediatric residents in this seminar. They're also quite useful for MIH, where you have a lot of issue with tooth structure. So actually it strengthens the tooth and also prevent further disruption of the tooth structure. Right, so this is some examples. So because it's colorless, right, it's just like a varnish kind of thing. So but you just apply on the caries surfaces, but it will become black like this. Okay, I wanted to get some photos from my colleagues who actively use SDF, but I think they did not manage to send me, so I have to take this from the article. So I think a lot more and more developed country also now using this. So I'm not sure about Erlangga, whether you have started using SDF, but I think later on in our country, we're also going to do a population-based trial to see in terms of, one is effectiveness, second patient acceptance, and also issue with having another one, potassium iodide, to minimize the staining. I think that's so-called, people are talking a lot about this, yeah, about SDF nowadays in relation to caries. So hopefully, I don't know whether this is going to be, because people are challenging, especially in terms of, are we going to use to still do, drilling and things like that, because this is very minimal intervention, and especially in the current COVID-19 issue as well, there's no, we want to minimize AGPs and all, so it become very much more favorable, in fact, even in our faculty. All right, I think this is some of my references. So I would like to take this opportunity to really thank Professor Dr. Taufan for this opportunity, for inviting me, and Dr. Jia and Dr. Ninu that assisting me for this session, and also last but not least to the faculty of Dental Medicine, University of Erlangga. I was on behalf of the University Malaya. I would like also to say this to University of Erlangga, to the students, because we also have, of course, after COVID, we also have a lot of outbound, inbound programs. So we hope, previous years we have students from Erlangga coming to the faculty. So we are welcoming, any future collaboration, undergraduates attachment, postgraduate attachment, or any research or future kind of like webinars or online talk like this, so that we can work together, more projects perhaps. So we really welcome that, and we hope for future collaboration with Universitas Erlangga. With that, thank you.
Thank you, Dr. Nur Azrida, for your amazing presentation. There are several things that catching up in my mind. The first one is for the systemic fluoridation, there are water fluoridation, salt and milk fluoridation. About salt and milk fluoridation, to be honest, this is my first time hearing this kind of thing. Maybe because it is not popular in Indonesia, as well as silver diamond fluoride that is effective to arrest caries. Maybe our student wants to ask more about this kind of thing about silver diamond fluoride. Maybe next, yeah. And the second one is if the fluor concentration in your location is below the standard of ppm, you can enhance the fluor intake from the systemic or local intake, like drinking water or using toothpaste. I saw an anti-fluoridation group mentioned in your presentation, but as far as I know, there is no specific location report about the fluor deficiency in water in Indonesia. So most of Indonesian citizens didn't know about fluor concentration in their area, except they are feeling the disadvantage from the water. And the last one is fluoride is essential to prevent dental caries. It inhibits demineralization, it promotes remineralization, and inhibits bacteria activity. I inform you once again, if anyone wants to ask, please simply press the raise hand buttons or type in the chat box. Jika mahasiswa atau dosen ingin bertanya, bisa langsung mengklik raise hand button atau mengetikkan pertanyaan di kolom chat. Silakan, dipersilakan jika ada yang ingin bertanya. Ya, pertanyaan pertama dari Ilvana Eva. Ilvana Eva mungkin bisa dibacakan langsung pertanyaannya. Silakan Ilvana Eva.
I think I can read from the chat box, okay?
Oh yeah, okay.
Yeah. All right, so I just open it. Okay, so so there's an issue in terms of staining, but what is lunak? I'm not sure what is lunak. Jaringan.
Lunak is soft tissue, doctor.
So
yeah, jaringan lunak.
Kasus. What is kasus?
A case.
Case.
If I may
you
translate the question. Yeah. If I may helping you translating the question. Do the SDF causing a staining in soft tissue, because there are several cases that Dr. Ilvana met. There is staining in mucosa around, and there is a multiple ulcer.
All right. Okay. I think issue with the staining. That's why I think the application must be very. You have to follow the protocol of how to do it properly, and then make sure all the isolation is properly done. And also, I think the use of petroleum jelly, the Vaseline, is quite popular. So yes, we observe if it's on mucosa, on the lips, on the gum, is actually stained. But usually, what we observe, it actually after several times it actually will disappear. But yes, I agree in certain cases, although I've not seen ulcer yet, but I'm not sure, you mentioned there's also ulcer. So it may be because it's also very alkaline, high pH. So that actually can cause, I'm not sure, for irritation perhaps to the mucosa. So we actually, of course, aware of this so-called side effects of this one. But I think that's why it comes back to us as a clinician. We must follow or adhere to a very strict protocol, so that to make sure the application can be done properly and to minimize the staining to soft tissue and other part of the, because if it's on the teeth itself, yes, because we want to help to treat the disease, right? But yes, I agree for the side effect, yes, they do have, but I think if we do it properly, we can minimize the side effect for as a clinician side. Am I answering your questions or is it mean differently?
Thank you, Dr. Nur Azlida. Bagaimana Dr. Ilvana Eva? Sudah saya unmute ini dokter, mungkin jika ingin menambahkan pertanyaan lagi. Mohon maaf dokter, tidak terdengar suaranya. Oh ya baik, sudah cukup ya mungkin penjelasan Dr. Nur Azlida. Ya, baik. Thank you Dr. Nur Azlida for the answer.
Right.
We are moving to the next question. Please, you can simply press the raise hand buttons or typing in the chat box. Dr. Gea, I think Dr. Gea is a little curious about milk and salt fluoridation.
Yeah.
Before this meeting, we already discussed about milk and salt fluoridation because we cannot imagine how that it will going that we put flour in the milk or or something
I think
like that.
because it's quite popular in European country when after they stop water fluoridation. For example, in UK, in certain schools, yeah, they have a milk fluoridation program. But for salt, I think we have to and to follow to fulfill like the concentration for the to make sure it comply to the concentration, to the safe dose concentration for the fluoride in the salt. But of course that one require just like water fluoridation, that's require you know, a lot of compliance from the manufacturer to do that, and of course different compound, what type of compound that you want to, you know, to inject in the salt, but they have this kind of mixture that they actually can do it together, because I think it's not that complex for salt fluoridation. But for milk, for example, in Malaysia we got actually dairy products company. Now we have like all these farm fresh and all these more and more dairy local dairy companies that would like to do this, but actually we found it a bit complex and it's very difficult if they don't have the instrumentation and to measure a proper fluoride. I think the dosing is very important, but for certain country, if they want to do it, they have to comply to the standard. So what you can imagine is something like they have to make sure, you know, the compound has been injected during the, you know, milk production, and to make sure that you have to measure it again and make sure it's complied, and then only it's, you know, package it as a standard you know, milk product, and then we can just use it like then just drink. But it's inside it, is you don't see the fluoride, it's a part of it, just like in the water, but it's in the milk form.
Oh, okay. And how the effectiveness, doctor, between water fluoridation and milk fluoridation, especially in primary?
Yeah, because I think the issue with milk, because it's just more, a few countries or few population are using it. So usually you cannot, when you talk about systemic fluoride, we cannot do, you know, this is, if public health intervention, you cannot do head-to-head comparison. This is milk, this is water fluoridation. You get what I mean? Because usually those with doing milk fluoridation is actually area without water fluoridation. For example, in the UK, only 10% have fluoride in the water. So this area with high caries, they go and try to do milk fluoridation. So it's very difficult to do the comparison because it's not feasible sometimes. You get what I mean? So, for example, if Canada, if Switzerland doing salt fluoridation, maybe the entire country. But for salt, you can see there are several papers actually comparing. What they compare is people who did not receive salt, meaning that those with salt fluoridation or standard salt. But you don't see salt versus water, something like that.
Water, okay.
So the head-to-head comparison is it's often difficult because situation does not allow you, unless suddenly, for example, Malaysia just suddenly stop water fluoridation, and then maybe next year we implement salt. Then maybe we can do so-called, retrospective kind of like comparison. Okay. Because usually one country we opt for one systemic fluoride. So that's why it's difficult to get head-to-head data comparison.
Thank you, Dr. Aslida, for your answer.
Oh, no problem. I hope that's answer your question.
Mungkin yang teman-teman yang lain yang mau
Any more question? Teman-teman dari angkatan 2018 ada yang ingin ditanyakan?
Ini ada Dr. Fania, Dr. Auli, Dr. Ara.
Oh iya. Dr. Fania, mungkin silakan.
Mau menanya?
Sudah bisa di-unmute, dokter?
I think this one
dokter,
I would like to ask, I've heard that SGF need to be applied at least twice before we can do permanent restoration. Yes, agree. For a lot of guidelines, clinical guidelines suggesting biannual application. True. Yes, that's true. To answer that, yes. A lot of recommendation is actually biannual because they want to, after you apply once, they want to see whether, you properly arrested, and then you have to call the patient again and then apply. But again, that's also subject to clinical judgment. It will be in certain condition. Maybe you thought that after you apply once, that you call patient for permanent restoration, and if you see it's being arrested, you are happy with to see that it's arrested properly, there's no more active caries. Maybe once is okay, but again, that one is subject to clinical judgment. But yes, for a lot of guidelines suggesting twice before you do permanent.
Okay, thank you Dr. Aslida for the answer. Dr. Fania, bagaimana? Apakah sudah menjawab pertanyaan dari Dr. Fania?
Sudah, dokter. Terima kasih banyak. Thank you, dokter.
Alright, thank you.
Ya baik, karena waktunya ini mungkin sudah habis ya dokter. Pertanyaan dari Dr. Fania tadi adalah pertanyaan terakhir. Yeah. So we have arrived in the ending section of this class. Thank you Dr. Nur Aslida for your amazing presentation and discussion. Terima kasih atas waktu dan kesediaannya untuk hadir dan membagi ilmunya bersama kami. Thank you for your time, and with you being here is such an honor for us. We are hoping to see you in a better condition. Semoga kita bisa bertemu ya dokter di keadaan yang lebih baik di Indonesia maupun di Malaysia.
Okay, inshallah. So stay safe. Thank you for the invitation. I hope at least some of you learned something today. So thank you again, and thank you for a very warm welcome. Although I'm here, but I can still feel the vibe. So thank you so much, and all the best to you. And I hope the COVID-19, go away quickly from.
Amin.
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 Yeah.
Alright, thank you.
Okay, thank you. Terima kasih juga kepada teman-teman dan staf FKG UNER yang sudah hadir di kelas IKGM 3 ini. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
So I can leave.
See you again.
I see you. Okay.
Terima kasih banyak Dr. Nur Aslida.
I can.
Thank you very much.
Session, ya.
Yeah.
Alright, thank you.
Thank you, Dokter.
Untuk mahasiswa jangan lupa untuk presensi di link presensi seperti biasanya ya.
Baik, Dok.
Baik, dokter.
Baik, dokter.
Terima kasih, dok.
Baik, Dok. Terima kasih, Dok. Mantap.
Ya, ini kita live juga nggak, Ge?
Iya sih harusnya, Mbak.
Terima kasih, Gea dan tim Dekota.
Terima kasih.